All right, it's 11:01. Are you folks ready in Portland?
Yes.
All right, excellent. All right, well, welcome everyone. Looks like we got a good group here today. This is Steve Axe from Chicago. Welcome for the latest edition here of ACMT National Journal Club. Thanks to the Portland group for putting this really interesting talk and journal club together. Today we'll be covering carbon monoxide and coagulation, anticoagulation, really a fascinating set of articles. Just to remind everyone, rules of the journal club, if you'd like to make a comment, use the raise your hand feature, we'll acknowledge you. If you're out there on Twitter, use the hashtag ACMTNJC. And today I'd like to thank, again, the Portland program with Zane Horowitz, Rob Hendrickson, leading the charge here, and their four fellows, Adam Blumenberg, Loren Murphy, Jen Love, and John Thompson. And with that, let me turn it over to you, Zane.
Yeah. Hey, thanks, Steve. Happy to present. Basically, we try to do a journal club almost every month, and we continue to look as over the years for more and more obscure topics. So we stumbled upon this pre-release of one of the articles you'll hear about today. And then we did a little deeper dive to find some others that sort of support it or dispute it. And so you'll hear the whole spectrum. Basically, I want to talk about carbon monoxide without the usual controversy of hyperbaric oxygen. Hopefully, we may only mention that word once in this hour. This is about a new controversy that has come up. And I think probably the best way to introduce it is with our first article, and we're going to highlight all four of our fellows that we have here. First article is a intriguing case report to get you thinking, does this happen more often? So I'm going to turn it over to our one of our senior fellows, Adam Blumenberg, for that.
Thank you, Zane. Cool. So we'll start by talking about this potential association of carbon monoxide and venous thromboembolic disease. And like you said, this starts with a case report that came out in 2018, and it was titled Life-Threatening Pulmonary Embolism that occurred immediately after acute carbon monoxide poisoning in the emergency department, and this is by Lee and others. And the title more or less says it all. We'll go through it in a little more detail, but this is kind of a documentation of kind of an unexpected event in a single patient that triggered some further questions. So the case is essentially the development of PE within 5 hours of diagnosis of acute carbon monoxide poisoning. Going into the weeds a little bit, this is the case of a 38-year-old woman who was found at home obtunded. She was brought to the emergency department where she was immediately intubated for altered mental status and for airway protection. She was initially tachycardic to 107 and tachypneic with normal blood pressure. And they did an initial echo, which showed essentially normal cardiac function. She was found to have a carboxyhemoglobin level of 28% and was given hyperbaric oxygen. And then on completion of her hyperbaric treatment, she had shock. Her blood pressure went down, and they did a repeat echo, which at this point showed RV dilatation and LV hyperdynamic state. And she was empirically thrombolized with TPA, and later on, a confirmatory CTPA did confirm a PE. So essentially, we have, in a very short period of time, a patient came in that since they had this data from before the hyperbaric treatment, they knew that there was no evidence of right heart strain. It did not occur. Did not appear that this patient had a pulmonary embolus before hyperbaric treatment, but afterwards she did. And so the question is, why did this happen, and why did this happen at this point in time? It was confirmed, as I said, later on that this was in fact a pulmonary embolism. These are images of her CTs. So going just to our Bradford Hill criteria, which is one method of assessing association and possibly causality, although we're not going to assess for causality in a case report. We see that this case does stand out in a few ways. There's a temporal association. This pulmonary embolism occurred very shortly after the carbon monoxide poisoning, there seems to be some plausibility, as we'll get into in further studies, and coherence, in the sense that there is some basic science data that supports this. And then in terms of experimental evidence, of course, we cannot make that assessment with a single case report, but in further studies that may be a closer linkage. And my co-fellows will discuss that as well. So like any case report, it doesn't prove anything. It does ask a question: is this a possibility? Is this a reasonable hypothesis? Does carbon monoxide cause venous thromboembolic disease? Potential arguments for this from a pathophysiology point of view would be the generation of free radicals, potentially platelet aggregation, possibly inhibition of TPA. Or was this all just random chance? Maybe this individual had a DVT in her leg and it just happened to embolize when she was moved from stretcher to stretcher. We would expect carbon monoxide to cause a systemic disease. Why would it only occur in one region of the body? So we don't know. It's a possibility, and it deserves further study. And with that, I will hand the mic over to Dr. Loren Murphy.
Great. Can everyone hear me okay?
Yes.
Yeah.
Thanks, guys. So I'm Loren. Thank you for letting us speak today. So my paper turns into an investigation of, do we have to worry about these events in a population that gets exposed to carbon monoxide? So I'll be discussing this Chung et al. Paper that was published 5 years ago. So essentially, this is a study out of Taiwan, and just as Adam was mentioning, there is this spattering of research information that's been coming out about the possibility that carbon monoxide could cause tissue damage and hypercoagulable states, which my other co-fellow John is going to be discussing at the end of this journal club. And so with this information, they generated the hypothesis is, could DVT or PE be linked to carbon monoxide toxicity? Carbon monoxide toxicity, as we know that it can cause apoptosis, free radical production, and tissue damage. So they utilized their national health system that is called the National Health Insurance Group in Taiwan, and this covers 99% of their population, which is really helpful. It's pre-approved for use by the IRB because the data is desensitized, and all this information from their claims has both outpatient, inpatient data, and it's all uploaded into a database that is readily accessible with also accessible a number of other patient factors. So they generated a retrospective cohort study to investigate whether there's this link potentially between DVT and PE and carbon monoxide. So their cohort were patients who were newly diagnosed with carbon monoxide poisoning. But what's really important is the way they selected this cohort was through an admission for carbon monoxide poisoning via an ICD-9 code for carbon monoxide poisoning as the primary diagnosis for their admission. There was no suggestion of a carbon monoxide level or any clinical sequelae or symptoms. It was simply an ICD-9 code. So they used the inpatient claims data for 10 years, and then they selected 4 controls for each cohort patient, and these were matched for age by groups of 5 years. They were matched, frequency matched also by sex and also by year of hospitalization, which I think is really important too, because you're going to capture some of the environmental changes that are going around that could influence the data. They followed every single patient until the notes that I've put in my PowerPoint here. So the study ended in 2011, and they followed them until the outcome of interest occurred, whether they died or were no longer part of their health insurance group. And don't worry, everybody, I did the math, and the 33,264 is exactly 4 times the 8,000, so you don't have to pull out your calculators and get ahead of me to make sure that that's accurate. I think another strong point of this study is they acknowledge that there's a number of confounders and other medical conditions that can lead to DVT and thromboembolic events. I've listed them here. These are the ones that they listed in their introduction, and they made sure to note these conditions on every single patient included in the study, and then made a subgroup of these patients for additional analysis, as they were also going to adjust and calculate incidences based on age group, sex, and some other treatments, which I'll get into here. So they took their carbon monoxide poisoning group, and they also separated two other subgroups, those who were treated with hyperbaric oxygen therapy and those who had acute respiratory failure. And they wanted to see if there was differences in this subsection of carbon monoxide patients and whether they were further at risk. And then they did all the appropriate statistics. So they did chi-squared test for differences in their categorical variables between patients. They used their student t-test to compare mean ages. They used a Kaplan-Meier method and log rank test to compare cumulative incidence of curves for both DVT and PE in all these groups. But the one that was most important for us and what we'll go through is their Cox proportional hazard regression analysis, which they used to calculate their hazard ratios and confidence intervals for their incidences of these conditions. So this is their table 1, which I always glance at quickly to make sure that there's nothing statistically significant that's a problem. And I'm going to highlight here, there was a significant difference in their carbon monoxide group and in their control group. So almost universally, the carbon monoxide group had a much higher incidence of every type of comorbidity. And this was a real hang-up for me in the beginning when I was reading and analyzing this study, because I knew that they were going to have to account for this in their statistical analysis, and I knew that they were going to have to be very ginger about the conclusions that they drew in their discussion. So I've highlighted the main results here, and I'm not going to go down into the weeds of all the tiny details. There were some things that were intuitive. For instance, in both the cohort and the control, DVT increased as you got older, and so that made sense. But what was really important for me is that they did compare the hazard ratio of DVT in patients without comorbidities. So carbon monoxide patients without any of the comorbidities they listed compared to controls without any of the comorbidities that they listed. And the patients per 10,000 person years had 5.39 times the incidence of DVT if you had a carbon monoxide exposure. Now, importantly, this is all for DVT. So they note very early on that there were no statistically significant differences for rates of PE in any of these groups or any of their subgroup analyses. They did find DVT incidence was higher, but not PE. Another little interesting point was that the highest relative risk divided up by age group was most significant and the highest quantitative change in the youngest patient group, so those under age 40. But that intuitively made sense to me because if you're looking at an overall change in the rate of DVT in a group that is exposed to something that's giving them DVT, the patients who are less frequently at baseline having this disease process and then suddenly having more incidence are going to have a higher relative risk. So that made sense. Then looking at their subgroups, I thought this was an area that I would have liked to explore a little bit more if I was in this research group, because they only compared hyperbaric oxygen treatment patients to themselves. In the carbon monoxide group, they did not compare these to controls, and same for the acute respiratory failure group. So in the hyperbaric treatment group, those carbon monoxide patients that required hyperbaric oxygen did have an increased hazard ratio for DVT of 6.89. Again, these numbers that I've posted are all for DVT and not for pulmonary embolism. And the same thing for respiratory failure. So those carbon monoxide patients that had respiratory failure had a higher hazard ratio of getting DVT. What's also important is, even though they say it's adjusted in their tables, it's only adjusted for age and sex, and they did not separate out the patients with comorbidities for this subgroup analysis. And they also, like I said, did not compare to the controls. And in retrospect, I think for hyperbaric oxygen, that's relatively reasonable, and I think it would be very difficult to get a large number of controls because you'd have to have patients who are getting hyperbaric treatment without carbon monoxide poisoning, but without any comorbidities. And I think that would be very difficult if we think about who's getting hyperbarics for reasons other than carbon monoxide poisoning. These are their Kaplan-Meier curves. I'm not going to dwell too long on this. They show that the incidence for DVT was statistically significant. We can see that most of the events occurred within the first year, and but they did have a higher incidence over time, and they followed these patients for 10 years. So there were small increments over time here. So again, going back, I knew they were going to have to be ginger about their conclusion, and I really amend this group because I really appreciated the way they described their conclusion. So they do say that, you know, carbon monoxide is an independent risk factor for developing DVT after adjusting for all these comorbidities, but they did not dwell on a causative factor. They just said it was associated. And I think it was also really important that they noted that, you know, there's other confounders in the hyperbarics, that perhaps these are just sicker patients and sicker patients are more apt to get DVT. And regarding the acute respiratory failure patients, they say, you know, we compare this to previous studies that, like with COPD patients, and those COPD patients with acute respiratory failure also had high incidences of DVT. So it's just showing that these are sicker patients and they're not spared from any of the other complications that other types of patients are going to go through in the hospital. So my assessment of this study, I think there were a number of really strong points, like it's huge number of patients. They were able to follow everyone really well. I think appropriately controlled for some comorbidities, but there's also some things I think I would have liked to see that were different. They note themselves that it's a retrospective study and there's confounders based in their own data system. So they're unable to control or select for patients who are smokers. They're unable to check people's body habitus. And also importantly, they can't check for medications. So they can't look at those who are on contraceptives and hormones. What was also interesting to me is that in the introduction, they list atrial fibrillation as an important potential comorbidity that could cause DVT or be associated with DVT. And they list an ICD-9 code, but then they do not include it in the rest of their study. And I'm not sure why that was dropped off. I'm not sure if they meant to include it in their introduction. And I know that that's a Pandora's box because people with atrial fibrillation are also going to be on anticoagulation a lot of the time. And so that may have opened up, you know, they may be preparing like a subgroup analysis of these patients, but I think it would have been nice to have those patients in there. Again, we don't have any idea on the severity of carbon monoxide poisoning in this group. We don't have their percentage carboxyhemoglobin levels, and we don't have their end organ disease. So it makes it difficult to compare those patients. But overall, I think this was a really great study and a good introduction to say that, you know, it is perhaps DVT can be a complication after carbon monoxide poisoning. And with that, I'll turn it over to Jen.
All right, that was a great review, Loren. Yeah, I think that was really well done. Interesting study. I was really struck by how they didn't flesh out severity of patients. You kind of just have to infer for the hyperbaric versus non-hyperbaric groups that they look different and were indeed more severe. And also, it would have been fascinating if they could have compared it to another group matched by severity, but I think it was very interesting. Before we pass the ball over here, if anyone has a question, feel free to raise your hand and we'll be happy to get you on the line as well. So if we'll give you a second to do that. Just passing this over. All right, great. All right, and we'll stop again after the other two papers. You know, just also a comment on the article that Adam reviewed, the case report. One thing I liked about that was, you know, the use of point-of-care ultrasound. They, you know, were able to see that RV dilation after the fact to point to the PE. You know, I think in toxicology, as much information as we can get from doing point-of-care ultrasound is really key. Hope to see more and more cases like that in the literature. All right, so I'm not seeing any hands, so Jen, why don't you take it away?
Sure. So the article that I'm going to talk about was actually just recently technically published in Annals of Emergency Medicine, though you may have seen it ahead of print online back a few months ago. And the article is entitled Risk of Venous Thrombus Embolism After Carbon Monoxide Poisoning, a Nationwide Population-Based Study. There we go. The understanding of the relationship between carbon monoxide poisoning and venous thromboembolism is particularly relevant in South Korea, where this study was done due to the heating system that they used. So you can see in the top picture, their houses before the 1950s were heated with this old heating system that relied on a fire pocket. And then the warm air from the fire would sort of warm the floor. And the exposure rate from this to carbon monoxide is actually pretty significant in that cracks in the stones in the floor would allow for carbon monoxide to sort of get into the home environment where people were. So just for understanding why, people might be more curious about this question in South Korea. So the hypothesis of the authors was that the risk of venous thromboembolism is highest during the acute phase following carbon monoxide poisoning. And they had two aims. The first was to identify the risk of venous thromboembolism after carbon monoxide poisoning and to identify the time interval during which the risk of venous thromboembolism is increased. And this was in part an attempt to improve upon the previous study, which Dr. Murphy talked about. And so the way that they did this was pretty interesting. I'm going to spend a little bit of time on the methodology here. They conducted a retrospective cohort crossover study between 2004 and 2015. This included only patients who had a single carbon monoxide diagnosis event during the time period, so no one with multiple exposures or multiple ICD-10 codes with carbon monoxide poisoning were included. They also excluded anybody who had been diagnosed with a venous thromboembolism in the 2 years prior to the incident carbon monoxide poisoning event. The cohort crossover methodology aims to compare the likelihood of a first ever event in the specific 90-day time period after the exposure to the likelihood of a similar event in the 90-day time period 1 year later. So I think this is best exemplified in the graphic on this slide, where they looked at the event being a venous thromboembolism following an incident event of carbon monoxide poisoning. And they looked at it in these bracketed periods in a cohort period, so 1 year after, and then 1 year in the crossover period. And the advantage to this methodology is that each patient sort of serves as his or her own control. The other thing that they did, so they identified both the exposure and the outcome using claims data, so ICD codes. They used a single specific ICD code for carbon monoxide poisoning, and then they used single specific ICD codes for both pulmonary embolism and deep venous thromboembolism. And then the other thing just to note is that the cohort of patients included both inpatients and outpatients, and they used this inpatient-outpatient marker in a subset analysis to sort of assess for the severity of the carbon monoxide exposure. So overall, just to note, there were 22,699 patients with carbon monoxide poisoning once between 2004 and 2015. Overall, only 219 patients developed a venous thromboembolism. So that puts the incidence at about 0.96%. So the overall incidence of a venous thromboembolic event following carbon monoxide poisoning is pretty low. But when they looked at the subset of patients who did develop a venous thromboembolism, you can see that the odds ratio of this event happening in the first 0 to 90 days for both all embolic events and pulmonary emboli and deep venous thrombosis is elevated in that 0 to 90 day period, and that's seen sort of in those red boxes in table 2. They then broke this down into 30-day periods, and you can see in figure B that sort of the highest odds ratio for these events falls in the 0 to 30-day period after the incident carbon monoxide exposure. In table 4, again, like I said, they sort of stratified by inpatients and outpatients, sort of as a marker of severity of exposure. And again, the effect was replicated. So you can see a higher odds ratio both for inpatients and outpatients in that 0 to 90 day period. And then again, it's replicated in terms of the 0 to 30 day period being sort of the highest risk. Again, the overall numbers are pretty low, but I think one thing that really stood out to me in this table 4 was that if you look at inpatients and examining the events in the 30-day periods, you can see that all of the VTE events happened in the cohort period, and there were no events in the crossover period. So it's pretty impressive when you have a table. I don't know, I always find it impressive when you have a table with a 0 in a column, showing that there were really no events in that crossover period and everything happened in that initial period. Oops, sorry, I didn't mean to go forward. So the other thing I just wanted to make note, this is in the supplementary tables of the article, the authors conducted a series of sensitivity analyses. So when they excluded patients who died from the cohort, they still saw an increased risk of venous thromboembolism in the 0 to 90 day period. They again saw an increased risk of venous thromboembolism when they excluded patients who had comorbidities and risk factors. So patients with common chronic medical conditions like cancer or COPD, and patients who had risk factors like a recent surgery or were on hormone therapy. When they eliminated those patients from the cohort, they again saw this increased risk in that 0 to 90 day period. I will point out that they didn't have the smoking status of patients, including in the risk factors, so those patients may have been included in this study. They again did a sensitivity analysis where they controlled for anticoagulation and antiplatelet therapy, as well as hospitalization for comorbid conditions in their patient population. That sensitivity analysis again produced similar results. And then finally, another thing that was interesting, they did a sensitivity analysis of patients who they deemed as having a serious venous thromboembolism. That was defined as death within 90 days of their venous thromboembolism diagnosis. 21 out of 219 patients had that serious VTE event. And again, the risk of a serious venous thromboembolism was also increased in that 0 to 90 day period. So I think overall, a very interesting study. I think it's important to point out some limitations. So the use of ICD-10 codes to determine the exposure and the diagnosis, there may be a significant amount of underreporting when you're relying on just ICD-10 codes. There's a lack of granularity to the data in terms of both the exposure time, things like transport time, the treatments that patients got, what their carboxyhemoglobin may have been when they arrived, what their vital signs were. And so sort of this is taking some very big picture data, whereas we know that some of these other factors may also be at play in the development of a venous thromboembolism. And then finally, there may be a component of surveillance bias at certain times where maybe patients were being tested more because testing was easier for either carbon monoxide exposure or venous thromboembolism, and so that may play into this data. But overall, I thought a very interesting study in this paper.
Okay, that was great. It's a fascinating paper. Again, any comments, please raise your hand. We'd be happy to get you on the line. Pass the baton over to John Thompson. Okay. Yeah, if you want to go for it.
Yeah, can you hear me okay?
Yep.
Great. So I'm John Thompson, junior fellow, and the paper I'm presenting today is titled Carbon Monoxide, Anticoagulant or Procoagulant by Nielsen and Pretorius, published in Thrombosis Research in 2014. So the authors provide a little bit of background. In carbon monoxide research, it appears that there's two big bodies of literature arising around carbon monoxide and its effects on coagulation. One supporting carbon monoxide as an anticoagulant with the hypothesis revolving around platelet inhibition, and then one body of literature with carbon monoxide presented as a procoagulant with reported enhanced platelet activation, decreased fibrinolysis by carbon monoxide modulation of different plasma proteins. The authors also note that there's a species-specific differences in clot structure on the macro scale, which may be very important, comparing animal models to human models. And so they compiled this review of the literature to compare and contrast these contradictory bodies of evidence. I should also note that in their kind of background, they report that anything of a carboxyhemoglobin concentration greater than 1% is abnormal, which I think may be at odds with kind of clinical thought, with ranges we usually go up to 3%, saying that that's allowable. So we'll start with the part of the research that focuses with carbon monoxide as an anticoagulant. The clinical evidence cited are case reports that they found in the literature of hemorrhagic infarction, subarachnoid hemorrhage, all associated with carbon monoxide poisoning. And these cases had a carboxyhemoglobin concentration up to 35%. The authors of this review do note that there was no assessment of platelet activity or function at the time of these case reports. And they then started some multiple preclinical animal models, and there are multiple mouse models where mice were exposed to carbon monoxide and decreased thrombus formation was noted. There were multiple animal studies performed at varying concentrations of carbon monoxide releasing molecules, and at high and low concentrations, platelet function and intravascular thrombus formation were decreased in mice and rats. We should note that the proposed mechanism of this platelet inhibition in the rodents was centered around guanylate cyclase dependent mechanism by which carbon monoxide decreased platelet aggregation. And in studies that we'll touch on, it's noted that in human models, the mechanism is independent of this enzyme, already highlighting some differences in the animal models and the human models. And then this part of the paper goes on to cite some human in vitro evidence, and they look at carboxyhemoglobin concentrations increasing in tobacco smokers, and showing a decreased release of adenine diphosphate and serotonin from platelets, as well as some studies showing decreased calcium entry into platelets inhibited by carbon monoxide. They then show that there's also some contradictory studies to that, where in similar studies of tobacco smokers, subjects who were exposed to cigarette smoke, they had increased platelet activation as determined by mean platelet volume following exposure to carbon monoxide. So in summary, there is some clinical evidence and case reports of hemorrhagic incidents in patients that were exposed to carbon monoxide, but the human in vitro evidence is really conflicting at this point. So now we're going to discuss the evidence that is in support of carbon monoxide as a procoagulant, which this paper goes into depth on this side of things. I should point out here that there are 95 references in this article. 37 of them are from the authors of the review themselves, and all of those articles are cited in this part of the paper. So they've built their research and their careers really on this kind of this part of the review, which is carbon monoxide is a procoagulant. So the clinical evidence that they discuss, there's numerous reviews where smokers with higher baseline carboxyhemoglobin concentrations or subjects that lived in more polluted areas had increased incidence of stroke or cardiovascular events. But we should note that carbon monoxide was not the only thing being inhaled by tobacco smokers or those breathing in fine particulate pollution. So there's a lot of confounders in those studies. There are some case reports that are cited of stent thromboses, myocardial infarction with reported, quote, normal arteries, atrial thrombus formation acutely, and these are all in patients with carboxyhemoglobin concentrations ranging from 2.6 to 52%. One study that was done on carbon monoxide poisoning patients with a carboxyhemoglobin concentration of greater than 10%, 48 of those patients did have increased plasma concentrations of prothrombin, fragment 1 and 2, plasminogen activator, inhibitor 1, and tissue type plasminogen activator. So these subjects' bloods also demonstrated a plasmatic resistance to fibrinolysis. Moving on to the in vitro and preclinical evidence, studies were completed on human plasma, which showed a decrease in the TPA-mediated fibrinolysis in plasma. And it was discovered in this study that it was the effects of carbon monoxide was really dependent on the presence of alpha-2 antiplasmin, and when that was removed, the effects of carbon monoxide were negligible on coagulation. It's also shown that carbon monoxide decreased thick fiber formation, increased fine fiber formation, which may be associated with a stronger clot. Here's a figure showing the effects of carbon monoxide on plasma coagulation kinetics, the light gray being plasma exposed to carbon monoxide, showing an increased velocity of thrombus growth and overall clot strength. This next figure demonstrates, again, an increased velocity of clot growth, as well as increased clot strength, delayed fibrinolysis, and prolonged clot lysis time in plasma exposed to carbon monoxide, again in the gray shaded area here. Through all of these experiments on human plasma, it was discovered that there may be heme-based modulation of fibrinogen function by the presence of what the researchers called a carboxyheme fibrinogen molecule. This was a carboxyheme product that was combined with fibrinogen. And so they started looking into this, and carbon monoxide being a modulator via heme products of fibrinogen, alpha-2 antiplasmin, and plasmin, and thereby affecting their activity. Subsequent studies did detect the presence of a carboxyheme plasmin molecule, but they were not able to isolate a carboxy alpha-2 antiplasmin molecule. And so then they took that information and they applied it to some preliminary translational investigations where they looked for detectable carboxyheme fibrinogen concentrations in patients that were hypercoagulable. One study took 20 healthy smokers, measured that concentration as well as carboxyhemoglobin concentration after they smoked 2 cigarettes, and found that 45% of the smokers were hypercoagulable and 45% had the carboxyheme fibrinogen compound. 20% of all of the smokers had both of those. They're both hypercoagulable and had the presence of carboxyheme fibrinogen. And the average carboxyhemoglobin concentration in all of those subjects was 5%. There were numerous other translational studies that looked at patients that were known to be hypercoagulable with cancers and had detected carboxyheme fibrinogen concentrations in those patients as well. Finally, they go on to discuss the ultrastructural findings supporting a procoagulant role for carbon monoxide. So these are scanning electron microphotographs of platelet-rich plasma thrombi obtained from, in slide A is a normal subject, slide B is a patient that smokes, slide C is a patient with type 2 diabetes, and slide D is a patient with rheumatoid arthritis. Excuse me. In these pictures, the three pathological states have increased thin fibrin polymer formation and matting, and all three states have demonstrated increased carboxyhemoglobin concentration in previous studies. So this thrombus ultrastructure, the review authors argue, shows enhanced clot strength demonstrated, which has been shown in the previous human plasma studies. They also do note that there are lots of reasons why someone with, for example, rheumatoid arthritis might have an increased risk of clotting that may not solely be related to carbon monoxide, but they don't go further into that. And then lastly, in regards to the ultrastructure and kind of touching on the differences in animal models, where some have shown carbon monoxide as a procoagulant and some have shown carbon monoxide as an anticoagulant, they look at the species-specific differences of ultrastructure clot formation. So this, again, are some scanning electron microphotographs of thrombi. Slide A is from a human, and slide B is from a rabbit, and then slide C and D are from a mouse and rat, respectively. Here highlighting the differences just in different species on the type of clot that is formed with the ultrastructure, suggesting that different species may rely more so on platelets versus plasma proteins for clot formation. So overall, they presented two large bodies of evidence, one with suggesting that carbon monoxide is an anticoagulant via platelet inhibition, as shown here on the figure, decreasing aggregation, and then another body of evidence to suggest carbon monoxide is a procoagulant by acting via heme plasma protein complexes, with heme fibrinogen increasing the velocity of their fibrin polymer formation and strength, heme plasmin and heme alpha-2 antiplasmin increasing clot lysis time. The authors do note that, while we have these mechanisms by which carbon monoxide can have both effects, we don't really know what this really means, and whether we can say that carbon monoxide is a procoagulant or anticoagulant. More studies need to be done. They note that these findings are species-specific, and it may even be, clinically significant specific based on the scenario, whether there is more platelet or plasma protein dependence on clot formation at a given time and in a given either animal or human. And that's all I have.
Great, thanks so much, John. That was awesome. So let me throw it out there to everyone. If you would like to ask a question, please raise your hand. And I think it's just a fascinating series of papers. And I guess what I kept wondering as you're going through the articles is going from bench to bedside. Like, what are the next questions you folks would like to ask? And actually, we have a question in the chat here. Let's see, from Marietta. It says, at this time, how might you apply the information lessons learned from Nielsen et al. In clinical practice? How might this impact your clinical decision-making, management, and treatment of patients? Any thoughts on that?
Yeah, that's a great question. In terms of clinical management, I think that it's something to think about if there is a patient with carbon monoxide poisoning, that their coagulation may be altered. I don't think that I would chase down anything and empirically search for evidence of clotting or evidence of bleeding unless there's a clinical indication for it. But I think it would just be something to think about in my mind. And just kind of have that back there, that there may be some abnormalities in their clot formation.
Exactly. Yeah, got it. Zane, did you want to go ahead?
Yeah, I would just like to, first of all, thank all my fellows for doing a superb job of presenting this, and kind of John kind of circling back to the Bradford Hill criteria answer that Adam posed with the case report. Is there plausibility behind this? And it seems, at least at a basic science level, there is. And I think the question that was just asked really leads into literally dozens of other questions that probably all need to be researched in the future. Originally, to make an analogy, when people had hip and knee replacements, and nobody would ever think of anticoagulating those people. They just had surgery, but it turns out when we studied them, they were at increased risk, probably due to immobility, of DVT. And so now the standard of care is to put, a knee surgery patient for 2 weeks of anticoagulation and hip surgery on 4 weeks of anticoagulation. So at least based on the third article that Jen presented, the highest risk is 30 days. The question is, do we need to randomize patients to yes or no, NOACs or some other anticoagulation for 30 days and see if that decreases the risk? We'd have to have an enormous N because, as Jen showed, the incidence is 1%. So in order to show a significant difference, you would need to do this in a place where there's a lot of carbon monoxide exposures. And again, the ideal place may be South Korea due to the Ondol heating system that's still pervasive throughout the country in pre-1950s homes, where there's essentially a fire pot burning outside the home that blows warm air under the floorboards, which are now half a century old and have cracks. And most of those patients are not, as it is in this country, suicides or even furnace problems. Those are all accidental exposures, and some of them pretty substantial. So I'm not sure we'd be able to do that type of study here, but multi-country, multi-centered study would probably get the answer to that eventually. But we'd have to enroll literally thousands of patients to see the difference. I think that the thing that this may highlight is to be vigilant in that maybe we should do, like I say, bedside ultrasound. Great in that first case, looking at the heart. Maybe we should be looking at people's legs if they're in the hospital for 2 or 3 days. I know if you're generally immobilized in the hospital for any reason that you're admitted, you end up with Lovenox injections on the internal medicine service if you're check enough boxes on their risk factor list. So maybe that's something else if you have to be in for 3 days of 3 dives of hyperbarics and there's some other risk factor, maybe that's something we ought to consider as well. So this opens up a lot of questions and provocative ones about this new association. And I want to emphasize this as an association still, and I always tell the anecdote that not all associations prove to be causations, because otherwise one would say, I noticed that the leaves fall off the trees before it snows. If we can only stop the leaves from falling off the trees, there would be no snow.
That's perfect. Yeah, Zane, I really do agree with that. I mean, I think what's wonderful about reading these papers carefully, as you and the fellows did, is I think we'll have an awareness, and I definitely think for my severely CO poisoned patients, definitely will look at them with a different set of eyes and be vigilant about coagulation. Loren, did you want to say something?
Yeah, I'd like to add something quickly, just to on the same vein that Zane was mentioning and what you were saying. It's like, what do we do with this information now? Because at the extreme, the suggestion is like that we are going to start using anticoagulation, perhaps outpatient for patients in the first 30 days, right? But that's an extreme, and we're clearly not there yet with the information that we have. But one of the things that my article was discussing too is, just as you were saying, Dr. Axe, is a heightened awareness that this is a possibility and maybe better education for patients. And if you think about your patient who's exposed to carbon monoxide, making sure that they're aware that these are signs to look for when they go home, but also if they're a patient with comorbidities who's at risk for DVT in the first place, these are patients that you need to make sure are well hooked into their primary care and have access to care so they know where to get help and to have them monitored. And that may be something that's more reasonable that I'm going to consider with my future patients.
Yeah, I completely agree with that. I think we had a couple of wrap-up slides, which I think we have to show. that you, Zane, and your pandemic look?
Yes. Oh, yeah. It didn't advance to the next slide, at least on my screen. But yes, that is. It's my new normal for going out in the world. I don't know if that one advanced into the slide set.
Oh wait, let me see if we can get it.
There we go.
There we go. You got that there? Excellent. And then we have one final wrap-up slide, which please let that burn into your retinas, everyone. Dr. Hendrickson.
And of note, this slide was made 4 years ago when we had a lot of flu, and it was basically holds true then and holds true even more so today. We were trying to tell people that don't be what the typical physician does and muscle through and try to work your shift if you have symptoms. Stay home. And ever more so applies during what's going on right now. So I don't have to go out wearing that mask anymore, hopefully one day.
Yeah, absolutely. Okay, and did you folks have any final wrap-up comments?
I think if we have 2 seconds, I'll mention a paper we found as a throwaway. This was actually a letter to the editor in January something this year, New England Journal. It was also a DVT article that it was on the International Space Station, where they were doing some study, and then, again, all the people on there were not physicians, but they were doing can you do ultrasound in space, and would you find anything if you do? And they were ultrasounding all their extremities, like literally every day. And one of the astronauts, presumptively a very healthy person, found a DVT in their upper extremity, an unusual place to find a DVT. Like us, they had to wake up the radiologist in the middle of the night to confirm that on Earth, but they did in fact confirm that he had a DVT, and they kind of got all the heads in Houston together and said, what shall we do? They looked around their medical locker, and they, sure enough, had enoxaparin on board, and they counted up how many doses, and they did some math and figured out how much to give and how much to stretch it out a little bit. And they immediately planned for the next resupplying ship that wasn't scheduled to go up for 42 days to bring Eliquis. So he was treated with enoxaparin for 42 days and then switched over to Eliquis. Now, one final problem that needed to be solved is that landing is the hardest part of the journey. And they said, well, it may not be good to be anticoagulated when you hit the earth at so many thousands of miles per hour. So they didn't consult a toxicologist, but they did figure out the kinetics, and they stopped his Eliquis 4 days before reentry. And he was able to make a reentry without any damage, muscle bleeding, or any other instances, and he never had any recurrence in any of his DVT. The question, of course, remains, why would a healthy person do this? Was this exercise induced? Was this something else? He had a complete workup on Earth, and nothing was found. But there you have it. Raises our next research question: does DVT occur in space?
That's crazy. That's a crazy scenario. The variables of reentry, that's also amazing. Okay, well, with that, why don't we wrap things up? I cannot thank you folks enough. And again, that was Adam Blumenberg, Loren Murphy, Jen Love, John Thompson, Rob Hendrickson, and Zane Horowitz from OHSU in Portland. Thank you so much. Our next National Journal Clubs, the next date is July 14th, followed by September 8th. I have the September and November Journal Clubs spoken for at this point. Still looking for a volunteer for July, so if any of the programs are interested in jumping in, please shoot me an email. Again, thanks everyone, and let's all stay safe out there, and hopefully we'll all see each other soon. Thanks, take care.